Hey team, Ben and Matt here from ATMA TV here with Andy Cahill. Thank you so much for your awesome presentation. He's just come off stage and we've got him for a few minutes.
Right, Andrew, first question, mate. The beauty of this conference is that we've got all ground up grassroots first responder sort of, initiatives going on through ATMA, and the conference is all about that. It's about having one session with everybody in it. So you've got police medics listening to academic research, you've got academic researchers listening to police medics talk. Can you give us, from your talk, the bottom line up front, just what the main points are of whole blood? Should we use it, and what's stopping us from doing that?
Yeah, so I mean, a really complex topic, but this was a perfect platform. ATMA is such a perfect platform to discuss this because you have a collaboration with so many people like you talked about. Regarding whole blood, I think one of the limitations that we have at the moment is the evidence, and that constantly is one of the key issues. But also it's a relatively new thing that has been reinvigorated by military and combat operations. So whilst we look to the US and they have demonstrated successful implementation of programs over there, it's not universal over there. And so there's rightly probably still some hesitancy here. I think evidence will come out in the next few years, but those 2 years essentially offer us a brilliant time for now to work out, okay, how can we implement it when the evidence does drop? Because it's no longer suitable to just wait until the evidence. We can start doing procedures and planning and training and equipment familiarisation now so that it supports it moving forward.
And what's your gut feeling? You mentioned a couple of studies like SWIFT. What's your gut feeling about what the outcomes of those might be?
Look, I'm hoping that it will demonstrate a survivable effect, but if not, again, one of the key things that I was pushing for, or to raise the conversation as to whether or not, if we're not finding a superior product, maybe there's alternatives in terms of the use on logistic advantages, particularly remote, rural, osteomedicine, and the military absolutely has roles in this.
And Andy, so blood you mentioned is quite a complex topic, and as Matt was saying, we've got a number of different providers in the room, and ATMA really specialises in having all spectrum of tactical medical providers. For somebody who doesn't have and won't have blood in their scope for them to be able to deliver, how does the introduction of bringing blood forward to the casualty and tactical space, how would that support or develop their capacity to save life?
Yeah, important, because I think if it comes down to the fundamentals, if your first responders and your paramedics and medics are then conducting the transfusion, I think it comes down to the other persons of the team to really focus in on the other elements, such as a rapid application of tourniquet, hemostatic measures in terms of direct compression. So they'll actually have an increased use because the clinician will be focusing on doing the transfusion.
I love that. That's fantastic. And it really comes down to, and what I'm hearing is basic saves lives, in the fact that the first responder keeps all that patient's circulating blood volume inside them, then they support the medic who's now bringing blood forward, and it's really that one-up model, isn't it? Like, what's that next person doing? How do I help with that life saved?
Exactly right. And the key to all of this is a really safe, protocolized method to do it, so that it is quite standardized in terms of training and then implementation.
Awesome. Well, thank you so much.
Thanks, Andrew, and thanks for tuning in to ATMA TV.